Good morning, everybody. Welcome to another edition of the EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief, and today I'm joined by our Medical Director, Dr. Kim Pruitt.
Hey, Chief.
Welcome, Doc. And Lieutenant Wayne Sears.
Hey, Chief.
Thank you for joining us today. I appreciate it. Going to talk about a V-Tac cardioversion call that you went on while assigned to Rescue 1, you and Engine 1.
Correct.
All right, so that's awesome. So you guys were dispatched initially to a 6 Delta, and the information you got was a 73-year-old female. Talk through what you were thinking on the way to this 6 Delta call, knowing that you're going to a 73-year-old female. What are the things running through your head?
Yeah, this call came in from out of district, in I believe the 7th district. So we're coming in a little bit later than we normally would have arrived. You know, with an elderly female, there's always a whole slew of problems that could arise that we don't know about from the dispatch that alarm room is unable to gather that information for. And they're pretty dynamic, you know, and so we go in there. My guys are real good about always doing all the diagnostical tools that we have, whether they're the EMT basics or my medic partner. So, you know, so I can pretty much get a good picture of what's going on with the patient. So, you know, so we don't know if it's going to be cardiac related. Trouble breathing calls always can go that direction. Or if she's just going to be a sick woman, or if there's going to be some other complication that we don't know about yet. So we kind of, you know, we're ready for anything before we get there.
That's a great point. I think the 6 Deltas, the trouble breathing, or the 26s, the sick calls, it could be pretty much anything, so you have to kind of be prepared for anything when you get there, because they end up being somewhat of a catch-all when people are having difficulty describing to the dispatch center what's going on. So that's a good call. All right, so you guys arrived out of district into 7s, and when you made contact with the patient, what did you guys see?
So this is it was a single-family home. There, we were directed to the back bedroom where our patient was laying in bed. And the family said they're kind of her caretaker. She's a limited mobility patient, an elderly female. Didn't look too bad, maybe a little bit pale. She was alert and she was talking to us. The family said that she had been feeling weak for several weeks. So no new acute symptoms within the last day that were different than she had been presenting for the last couple of weeks. But, you know, she was alert, she was oriented, she was talking to us, she looked maybe a little pale. You know, my guys are kind of getting ready for a trouble breathing call, but she didn't look like she was dyspneic or if she was having any trouble breathing. So, you know, I asked her about her chest, and she didn't have any chest pain, but she said that she was feeling weak and dizzy.
And did she elicit any history to you guys at that time when you were asking questions?
You know, she really wasn't giving us any history. The family, I had, you know, the other lieutenant go talk to the family to try to gather a better history, and so he was working on that, and we were working on a 12 lead right away and trying to get going on that.
All right. So based off the chart, it looks like your initial vital signs is you had a heart rate reading of about 280 is the way it came back. Blood pressure 96/46, satting well, 96% on the room air, about 18 respirations with a 284 blood sugar. So as soon as you saw that heart rate, and did it match what you were feeling? Obviously, was it a palpable pulse?
Yeah, it matched, and so we got out of the 12 lead right away due to that, and yeah, so we put the first limb lead on. Monitor's already reading V-Tac. You know, that was kind of new to me. I didn't realize we had one lead will read the whole. You know, we didn't really need anything more after that. But yeah, you know, the 12 lead came back as V-Tac, and that's what directed our care at that point.
Yeah, absolutely. So you were taking a look at that 12 lead. You saw that V-Tac. Now, the rate is obviously way up there. Talk us through, if you can, because we've had recent QAs where we've had some EMS providers that identify it as SVT immediately when they see a rate in the 200s, close to 300s. Can you talk about what your differentiating factors are when you're reading these 12 leads to know what's SVT and what's V-Tac?
Yeah, just the wide complex, the fast wide complex is what directed us, you know, to identify it as the ventricular rhythm.
Awesome. Mm-hmm. All right, so now you know what you have. What was your thought process, or what was your next steps after you recognized the rhythm on there?
I just wanted to be real solid that she wasn't going to crash right there on us, that she had enough pressure, she was perfusing enough to, you know, I was like, do we need to treat it right here in her bed? 5.5 was on scene at that point. You know, and then because she was alert and talking to us and stable, shocking her immediately, I don't know if that would have been appropriate. So I felt like we needed to get an IV and sedate her, you know, and then go through the cardiac protocol for cardioversion. So yeah, we did decide to load her up in the back of 5.5 before we did any more treatment.
Okay. So we did the 12 lead. We have the IV going. You have a 20 gauge in the right AC. We have the pads on already at this point.
Yeah.
And then you opted to give Versed IV. And then what did you do after that, or what was your next steps after the Versed?
We got the line. We gave her we sedated her. I asked her how she was feeling. She really didn't say that there was any changes or she felt the medication necessarily. So I was like, all right, let's wait another 30 seconds and see if she can kind of zone out a little bit before we deliver a shock to her chest, this poor old lady. And so we waited another minute or less, and then I was like, all right, let's just go ahead and give her the first 100 joules. And we all agreed on that. We shocked her. She was still alert. She definitely felt that one, and it looked uncomfortable, but it was necessary. And then we reassessed the rhythm. There weren't any changes at that point. But also, she was becoming more lethargic and kind of out of it, which is more sedated, which was a good thing.
Mm-hmm. And that's a great point. And what I wanted to discuss a little bit today, too, was we have two ways to look at stability, like hemodynamic stability, and one is the blood pressure. She's borderline 96/46. It's probably pretty low, but I think the marker for you and when you made your decision was just that level of response. She was really alert when you started talking with her and first met with her, and then it slowly progressed to becoming more and more lethargic. So at that point, you identify that that's symptomatic, they're unstable, so I'm going to treat this with electricity. So you guys did a fantastic job on that. So talk me through after the first joules, the first joule setting was 100.
Correct.
And you delivered the synchronized cardioversion. Did it convert?
No, it didn't change her rhythm at all.
Okay. And what was your next steps after that?
So we just, the progression in the electricity, we gave her the next step up, 200. And then we delivered that. At that point, she was sedated. Her eyes were closed. She didn't react to that shock, which was better.
Yeah. Yeah.
And then finally, we had conversion at how many joules?
At 360.
360.
Yeah, so that we did deliver the highest dose, I believe, on the third one, and we were sort of like, well, we were trying to look at the next step after if this didn't work.
Yeah.
But and we were en route to the hospital at this point, and we delivered that third shock, and it converted her to a sinus rhythm, which wasn't very organized, but it was a sinus rhythm. It was much slower, reduced the rate quite a bit, so that was a good thing.
That's awesome. That's a fantastic job. So, Doc, talking through this patient, obviously was progressive to unstable, and we decided we were going to treat with electricity. Talk through with us how we should anticipate handling patients who are still stable. They're still talking to us. Blood pressure is good, but their rhythm shows something like what we're seeing today.
Yeah, absolutely. I think you did a great job stepwise going through the algorithm here. Other tools you have in your toolbox that you can consider using, maybe an antiarrhythmic if they're just persistently staying in a wide complex tachycardia, like maybe giving a amio bolus, either 150 if they're stable. And then I always like a little magnesium too. It's a little extra shot of a vitamin, but it's amazing how well sometimes it can do to just calm down an irritable heart. So if you were maxed out at the 360 and you're still wondering what to do, electricity in an unstable patient is always the right answer with a wide complex tachycardia, but there's some other adjunct treatments that may help as well. And you can do those if you're not quite to the electricity point yet and you're knowing they're kind of on that borderline like she was when you first got there. Those medications may make a difference early and keep you from having to deliver those uncomfortable shocks.
And Lieutenant Sears and his team, they did a great job of escalating those joule settings as needed. They finally found the joule setting where it made the conversion. But you had mentioned still considering the amio and mag even after a cardioversion. Can you talk through that real
Even
quick?
after, because we, in the pre-hospital setting, it's really hard to know what preempted her to go into this rhythm to start with, and the amio, having that on board may just help reset those ventricles to start pumping correctly and continue pumping correctly. And the mag as an electrolyte to just restabilize the myocardium.
Perfect. I'm going to keep you on the spot with one more question. So we're on this call. We're deciding whether we want to use fentanyl or we want to use Versed prior to delivering the cardioversion. What are your thoughts on either one, pros, cons?
Pros and cons on each. It sounds like this one worked perfect because the sedation was able to last through your progression of the escalation of the joules, which was nice because that was also probably progressive pain. It's kind of dealer's choice here. I tend to prefer fentanyl a little bit more because most of the time, like one shock will work, and that fent is more of a pain controller. Where if you're really paying close attention to their mental status to help guide your treatments, Versat's going to change your mental status. So then you don't know if it's your medication or if it's their actual hemodynamics. And fentanyl usually won't make them as sedated, but there's pros or cons to either one. And in this case, the Versed seemed to be the right choice because it lasted through her whole progression of treatment. So,
Awesome.
And it didn't seem to change her hemodynamics that much as well. The other consideration with Versed is if you have a very tenuous blood pressure, it has more of a tendency to decrease the blood pressure than fentanyl does.
Makes sense. So after all these treatments are provided, you guys are still in transport to the hospital. Any changes in the patient's condition or?
She remained sedated. Her rhythm became more organized, and by the time we got to the hospital, it was a relatively normal rhythm at a good rate. And I believe her blood pressure did rebound to a healthy level. So that was good. So everything was looking good and going in the right direction. And, we dropped her off sedated still at the hospital.
Awesome. That's a fantastic job, a true save. You guys were able to make a huge difference on this call. So you did a great job with you and the Engine 1 team. That's awesome. Well, that's all we have for today. If you guys have any cases that you want to share with the group, please let us know. Go through your 7-8 or enter it into SharePoint. Come record with us, and we'll talk through these cases. Until then, thanks, LT. Thanks, Doc.
Thanks,
and we'll
Thanks,
see you
Chief.
next time. Good job.